Hey everyone, we are finishing up our discussion of vaginismus this week with our vaginismus compilation video. So I'm going to be talking about the condition itself, different therapies, support groups, different things to think about, and also talk about, things to talk to your provider about when you go in and if you have vaginismus. So this, condition is very near and dear to my heart. I've dedicated a lot of my practice to the treatment of vaginismus. So if you have this condition and you don't have a provider that seems to be understanding or know kind of what they're doing with it, please reach out. I'm happy to answer questions for you and hopefully kind of guide you in a direction that could be helpful to you. So, the short of it basically is that vaginismus is an uncontrolled spasming of the muscles at the entrance to the vagina in response to pain or to the anticipation of pain. Is originally described way back in the Middle Ages, actually. It started being described then as kind of an uncontrollable spasm that would keep women from being able to consummate their marriage. And then it was later described again in the 1800s as basically a spasming of the sphincter vaginae, this kind of archaic term for the vaginal introitus, but once again kind of associated with this inability to have sex. And they were looking at it at that time also as one of the potential causes of infertility, saying, obviously if couples can't have sex, they can't have, get pregnant, so we should really look into this. It had kind of a torturous course after that, and it was kind of thrown around being, is it just a condition of, hysteric women? Is it something that's more all in the brain? Is it just a psychiatric diagnosis? And really up until, recently, actually, technically, even still this day, the main diagnosis of vaginismus is found in the Diagnostic and Statistic Manual, which is kind of a textbook for psychiatric illnesses. And it's listed under kind of the heading of genitopelvic penetration or genitopelvic pain and penetration disorders, so GPPPD. And I honestly think that's a misnomer. That's not correct. Because yes, it does cause pain with penetration. Yes, obviously that's the case, but it's its own entity. It's not the same as just saying, oh, you have painful intercourse with insertion. Like, you can have that and not have vaginismus. You can't really have vaginismus and not have pain with penetration. So I think they're completely separate. So, nowadays we have been able to use medical technology to really kind of identify the specific muscles that are spasming and to look at things from actual muscle strength and contractility in response to that spasm. And that's one of the papers that Peter Pasek put out, kind of doing the actual degree of spasm itself and saying, hey, this correlates with this specific degree of vaginismus. So you can look at that. That's on open access on sexual medicine, the open access journal of sexual medicine. So when it comes to diagnosing this condition, it is really a clinical diagnosis. You look at the patient's history, they say, hey, for my entire life, I've been unable to tolerate any type of penetrative activity, whether that's sexual, whether that's, a pelvic exam, putting in a tampon. And then when you do an exam, you can actually see anything from just those muscles tightening up to sometimes patients will have complete kind of leg lock, or like I said, in severe cases, they'll dissociate. They'll kind of, start, they'll try and climb away from you, get off the table, whatever it may be. And so looking at those two things can really kind of pinpoint that diagnosis of vaginismus. Now, like I mentioned I think it was my video yesterday, if you're going to send a patient who has vaginismus to a sexual medicine specialist, you don't have to say, oh, this is Lamont-Pasek grade 4, or this is, whatever. Like, you can just say vaginismus. That's totally fine. But if you're a patient and you want to kind of see the severity of your disease, you can look and use that scale. That's kind of the most, well-described one. There are some other scales out there, but the Lamont-Pasek one is the one that we typically use the most. Now, when it comes to the actual pelvic exam for patients with vaginismus, it is very, very, very important to collaborate with the patient if you're the provider. Likewise, if you're a patient, talk to your provider about that. And if you find someone who's basically just blowing you off or saying, you know what, you just need to relax, deal with it, get out of there. You don't owe them anything. Like, that's something you don't have to sit there and just take it. And I hate to use that term, but like, not only is there not any type of, gold medal for going through a painful pelvic exam, but at the same time, like, you deserve better than that, than to have someone say, this is in your head, just relax, or why can't you just relax? You're making my job worse. I've had patients come in and say these things like that. Other providers have told them that. And it drives me batty. So if you're a patient and you are getting a pelvic exam and that provider is not, respecting you, or you feel that they're not listening to you, say, hey, I'm not going to do this, and leave. And that's totally within your right. Now, obviously, if you're hemorrhaging and you're in the emergency department and like it's life or death situation, that may be something different. But, you're just regular pelvic exam, that you have the right to ask for a small speculum. We have pediatric size speculums if you have to have a pap smear that we can use, that will, we can insert into children. And so, you don't have to have the big giant metal speculum. No, you don't have to have that at all. So when it comes to treatments for vaginismus, the kind of long-standing approach was to use typically a combination of kind of counseling and also some form of pelvic floor physical therapy, whether that's with dilator therapy that's guided by a pelvic floor physical therapist or a healthcare provider, or kind of on your own. And there are a lot of self-help books out there that kind of go through this and give you different techniques for that. I'm not going to go through those specifically because I personally do not help patients with like specific dilation techniques. That's kind of something that I don't do. I have a lot of pelvic floor PTs I refer patients to that do a really good job of that. So I'm of the mind that if someone does it better than me, I'm probably going to send my patients to that person. Counseling in terms of the psychologic therapy there's a lot of different ways to approach this. Typically, cognitive behavioral therapy was kind of the mainstay, but also talking about kind of avoidance therapy too, ways to kind of desensitize your body to that fight or flight response, because that's what's really going on. If you anticipate pain, your body is going to instinctively try and protect itself. If you see someone coming at you in an aggressive fashion, you don't even have to think about it. Your body already starts pumping adrenaline into your system. Your pupils dilate, your heart rate increases, all this type of, sympathetic or fight or flight response to hopefully get you out of danger somehow. Well, laying in a very compromising position on a table with someone saying, okay, I'm about to insert a speculum into you or I'm going to have sex with you, and knowing that it's going to hurt kind of does that same type of response. So things to desensitize that can be very, very helpful. Saying, okay, I understand what's going on. I know that, I've never had a patient that says, what I want to do today, have a pelvic exam. But knowing that this is not going to be uncomfortable can help kind of calm down that response too. And there are lots of different therapies for that. I've mentioned EMDR, or eye movement desensitization and reprocessing, is a technique that was originally developed by Francine Shapiro for people that had trauma, specifically combat veterans who have PTSD. Vaginismus is basically you get PTSD with it. Time and time again of painful penetrative activities, it causes trauma and it rewires your brain into saying anything going towards the vagina is going to cause pain. So EMDR can be very helpful in releasing that or removing that, and kind of allowing that processing to take place. There are other therapies that work very similarly to that. Once again, I'm not a psychotherapist, so if you have knowledge of those other therapies, please let me know. The EMDR is one I have the most experience with. Medications, if you know that you're going to be very anxious about a pelvic exam, you may want to consider doing some sort of medication like Valium or another kind of anxiolytic. Now remember, from a legal standpoint, if you have to sign any consent forms or things like that, make sure you do that before taking your Valium, because if you sign something while you're on a sedative, it technically is not legally binding. So, other therapies, kind of the newer therapies out there, really are focusing on ways of actually causing the muscles or affecting the muscles themselves. Now, pelvic floor physical therapy in terms of internal work and getting those muscles to relax is a relatively new, type of therapy. It's very successful for a lot of patients with vaginismus. And for some women, especially with kind of lower grade vaginismus, they can, kind of overcome their condition with just counseling and PT alone. Typically, once we get into around grade 2, 3, definitely, 4 or 5, we also want to consider doing some adjuvant therapy too. And this can be using things like, intravaginal Valium, which doesn't have the same type of systemic response that you get when you take it, orally, or Botox. I do quite a bit of Botox for pelvic floor dysfunction and for vaginismus specifically. As I've mentioned before, Dr. Pasick was one of my mentors. He kind of trained me in his technique for Botox and sequential dilation for patients with vaginismus. So it's a therapy that I offer for patients, and it's very, very successful in helping them overcome their condition. And for a lot of patients who've never been able to consummate their marriage, we can get them to where they're doing that. And I have patients that were previously unable to do that now come in for, pregnancy care. So there's a lot of great resources out there. It's just difficult to find providers that are really knowledgeable about this. So if you are a patient and you say, what, my local, primary care doctor, OBGYN, whoever doesn't really know what vaginismus is, get on some of the support groups, look at some of the vaginismus, postings online. Dr. Pasick's webpage had a bulletin board or kind of a patient group for that. There's lots of things on Facebook or Instagram, and there's other, people that really are knowledgeable in the treatment of vaginismus from a medical standpoint. Not to mention the bevy of other practitioners from either the psychotherapy, sexual body work, or physical therapy that are really good, kind of resources for patients with the condition. So now let's say that you say, okay, I have this and I'm going to see a gynecologist. I'm going to see a new doctor and I need a pap smear. So what are some things to kind of take with you to that visit? So the first thing is to let that provider know, hey, I have vaginismus. Pelvic exams are really uncomfortable for me. Can you use a small speculum? If they're using metal speculums, is there a way you could heat it up? If they're going to, sometimes, like I've mentioned, patients tolerate or do much better if they're able to actually see what's going on. So, seeing if most gynecologist offices have, or at least they should, have a mirror so that they can point out things for patients. So kind of watch the exam, or you may even, feel more comfortable actually inserting the speculum yourself. If you're able to tolerate, self-insertion without having that vaginismus response, as opposed to someone else kind of inserting something. Like I said, I'm a big fan of communication, and I always tell my patients, hey, if I'm doing anything that is uncomfortable, painful, whatever, let's be in constant contact throughout the exam. And especially when I'm doing a pelvic floor exam, that's so important to say, okay, where are you feeling this? Are you feeling this just where I'm touching? Is it radiating any place? Is it a lightning bolt type feeling? Is it sharp? Is it dull? What is it? And so, tell your provider, hey, this is what's going on. This is what I'm feeling. From a provider standpoint, if you take care of patients, be very, very cautious with your word choice. There are certain trigger words that for patients who have been sexually assaulted, sexually abused, or maybe just have a history of trauma that may kind of bring back those things. So you can always ask your patient, do you have trigger words that you want me to avoid saying? Are there things that, we can do to make this, exam more comfortable for you? And so really just kind of work with your patient with that. They will very, very, very much appreciate that. Warning signs, for patients, if you have a provider that says things like, well, it's all in your head, you can just get through it, or just breathe through it, or, well, maybe your partner's just too big, maybe your vagina is just too small. I had a patient come in that said that her previous, gynecologist told her, this is just your body and you just need to deal with it. It drives me nuts. That's not okay. You don't go into medicine to tell someone you just need to deal with it. If you don't know how to do it, if you don't know what to do, find someone who does. And if you're a patient and someone tells you, hey, just drink wine and you can have all the sex you want, you need to get on out of there, because they don't know what the heck they're talking about. Wine is not a panacea. It does not fix everything. If you like drinking wine, great, drink some wine, but don't expect wine to fix your problems, obviously. The other thing that we see a lot of times with vaginismus, I know I'm kind of jumping around here and I apologize, is that there's a very strong correlation with very strict upbringings and a lot of purity culture. And this is something that, I think deserves kind of its own talk. But the idea that, sex is going to be painful. All women have pain with sex. With that first time, it should be painful. It was supposed to be. There are kind of these vaginismus trolls that come around on social media, and they post things like women, are supposed to have pain with sex. This is, sex is much better for men. So if women can't have sex, they should, not have sex again. Like, get back under your bridge, troll. You have no place being here. And I don't even respond to those. If they post those on my page, I don't even give them the time of day, because that's not, like I said, not even worthy of addressing. This is not a punishment. This is not, you did something wrong and so now you have vaginismus. Like, no, that's not how this works. It can be a response or a result of traumas you have experienced, but never, ever, ever think that you have vaginismus because of something you did wrong. Like that's not a correct medical statement at all. You deserve better than that. So, for patients who have kind of grown up in purity culture or very strict upbringing, sometimes education is some of the most important things we can do, and say, hey, look at your body, like look and see what's actually going on. Have you ever actually looked at your vulva? Do you know where things go? Do you know what the anatomy is? It's still surprising to me. I've been doing this for a long time and I still have patients that think they just have two holes. One that poop comes out of and one that babies and pee come out of at the same time. Like that's not anatomically correct, folks. You have a urethra, you have a vagina, and you have an anus. And unless there's something that has happened that has caused that to not be the case, that is the anatomic structure there. So take a look at your anatomy, figure out what it looks like normally, understand your own body and be comfortable with that, because that's a blessing you've been given. So the other thing, working with partners, making sure that there's many, many, many ways to have sexual intimacy besides penetration. And so it's not all about, penetrative sexual activity. Like I have many couples that are sexually intimate and who can't have penetration for some reason or another. But if you have vaginismus and that's the thing that's keeping you from doing that and you want to do that, then let's work on that. But remember, if you're like, I don't really care. It doesn't bother me to not have penetrative sex. It doesn't bother my partner. Great. That's totally fine too. So yeah. I know this is a little bit of a longer video. Like I said, I kind of go off on tangents with it, but I'm very passionate about vaginismus. And if you have any questions or concerns, or you are suffering from this condition and you haven't found someone that can help you, please reach out. Let's work together and find ways to make that happen. So anyway, I hope you have a wonderful rest of your day and a wonderful rest of your week. Next week, we'll be talking about low sex drive, and that will be great. So I'm Dr. Corey Babb. Take charge of your own health. You deserve the best health care that you can get. Talk to you later.